The second aim is to decrease the radiation dose by decreasing the activity of radioiodine in low-risk patients. So there is one rule is that radioiodine should not be given in the absence of benefits to very low-risk patients. But when the patient is at low risk, the minimal effective dose activity should be administered to avoid cancer and leukemia, abnormal pregnancy outcome, and all these side effects, which may be significant. And also, this low dose, low activity may minimize the cost and duration of hospitalization. So we have data on the use of recombinant human TSH and 100 millicuries, but discrepant results were reported with the use of 30 or 50 millicuries. And so we decided 5 years ago to launch a trial with 30 or 100 millicuries and recombinant human TSH or withdrawal. So this was a prospective randomized trial on 752 patients in which patients were randomized among 4 arms. ESTIMAP study is a French study, and HILO study was a British study. Very similar. So we had 26 centers. This study was sponsored only by the French Institut National du Cancer and not by GENSA. We did not we had no role in this study. So patients were low-risk patients, age over 18 years, low-risk patients with T1 or T2 and 0. They had total thyroidectomy and T4 treatment for 1 month, and inclusion was between March 2007 and February 2010 in 24 French centers. And this trial was an equivalence trial by a 2 to 2 factorial design, aimed at showing that the activity of 30 millicuries and 100 millicuries provide exactly the same ablation rate, and that the use of recombinant human TSH or thyroid hormone withdrawal also provide exactly the same ablation rate. So we included 752 patients, and these were treated with radioiodine, and this is the uptake on the post-therapy scale. Most of the patients had visible or significant uptake in the thyroid bed, which was below 2% in the large majority of patients. So these patients had a total thyroidectomy before inclusion in the trial. 27 patients, so 3% of the patients had persistent disease shown by uptake outside the thyroid bed, in lymph node, lungs, or both, and were excluded from the analysis. Now, the main criteria was ablation rate at 8 months based on neck ultrasonography and RH-TSH stimulated serum thyroglobulin. When these 2 tests were normal neck ultrasonography and undetectable serum TG, ablation was complete, but when one of these 2 tests or both tests were abnormal, ablation was incomplete. So the results: neck ultrasonography was normal in 94% to 97% of patients. Recombinant human TSH stimulated TG was undetectable in 94% to 96% of patients, and both tests were normal in 90% of patients to 94% of patients. This and this were not significantly different. So there was only 1.2% difference between the ablation rate with recombinant human TSH compared to thyroid hormone withdrawal, and a difference of 2.4% between the use of 30 millicuries and the use of 500 millicuries. And the conclusion of this study is that either 30 millicuries or 100 millicuries, and either recombinant human TSH or withdrawal provided similar ablation rates. So 53 patients had an incomplete ablation, and most of these patients were followed. And for 26 patients, all diagnostic tests became normal. So there were only 3 patients who had clinical recurrent disease. Now, the short-term side effects, lacrimal problems, were more frequently observed in patients treated following withdrawal, these 2 bars, as compared to patients treated following thyroid hormone with recombinant human TSH. The salivary problems were similar in all 4 groups. Of course, there was no hypothermic symptoms according to the Bilibid scale when using recombinant human TSH, and finally the quality of life was better in these green and blue groups, which corresponded to recombinant human TSH. So this trial showed an equivalence in ablation rate at 8 months of 30 millicuries compared to 100 millicuries, and using recombinant human TSH compared to thyroid hormone withdrawal. It validates the use of recombinant human TSH and 30 millicuries for ablation in low-risk patients after the total thyroidectomy. So now it's so easy to ablate these patients that the question is ablation needed in all low-risk patients? And the next equivalence trial will be in patients with T1 between 1 and 2 centimeters without lymph node metastasis or low visible metastasis on neck ultrasonography, and we'll compare the outcome of only follow-up, no ablation, compared to 30 millicuries following recombinant human TSH. Another concept is empiric radioiodine treatment during follow-up. So this is a scheme of use for in the European consensus, starting with total thyroidectomy radioiodine ablation at 3 months treatment with T4, TSH, and thyroglobulin, and at 9 months recombinant human TSH for thyroglobulin testing and neck ultrasonography. So in most patients, low-risk patients, TG is undetectable, neck ultrasonography is normal, and the patient is cured, definitively cured. But in some patients, TG is detectable and will increase with time, and then what to do in these patients? In the past, so this in 1985, you had the ITC, the International Thyroid Congress, in this term in Sao Paulo, and for my first presentation in Brazil, I showed some data arguing that an empiric treatment should be given to these patients. But things have changed since 25 years, and now we have post-ablation whole body scan, which are extremely informative. And we have neck and chest CT, we have neck ultrasonography, we have FDG PET scanning, which were not available at that time. So we reconsidered these patients in our series of Budgeviv, and we had 34 patients with a normal post-ablation total body scan and persistent elevated serum thyroglobulin. So these patients had the treatment, empiric treatment with radioiodine and the FDG PET scanning. And you can see here, by comparing the post-therapy whole body scan with FDG PET, that the sensitivity of whole body scan was much lower than that of FDG PET scanning. So among patients who have a normal FDG PET, 12 patients, only one had an abnormal whole body scan with radioiodine, and among patients who had an abnormal FDG PET, 32 patients, 5 patients had an abnormal whole body scan. So these patients had an abnormal whole body scan, but none of these 5 patients had response to treatment. So we believe that these patients with persistent elevated serum thyroglobulin increasing with time, we should start with FDG PET scanning, and only those with normal FDG PET scanning should radioiodine treatment administered. So in only one of these 34 patients. So the indication of empiric radioiodine treatment is becoming very, very rare. Now, the radioiodine can be used for treating persistent and recurrent disease in the leg or at distant sites. And to search for recurrent disease in the leg ultrasonography is probably the most sensitive tool, with a good sensitivity of some of the characteristics of neck ultrasonography, such as loss of film and microcalcification or cystic component, the specificity of 100%. So this is a typical lymph node metastasis, which should be submitted to fine needle aspiration biopsy for cytology and TG in the washout fluid. Both tests, cytology and TG in the washout fluid, should be performed during fine needle aspiration biopsy. Neck ultrasonography is a sensitive examination, but the sensitivity is not as far from being 100%. For central neck here, you see that only 30 to 64% of lymph nodes are found when comparing neck ultrasonography to results of surgery. And for lateral neck, it's better, but it's not 100%. So treatment of recurrent disease in the neck may rely on radioiodine. Problem is that when lymph nodes or recurrence in the thyroid bed is large, over 1 centimeter, the results are not so good. In 3/4 of patients with neoplastic foci over 1 centimeter in diameter, there is persistent uptake after 3 treatments with radioiodine. But in patients with small neoplastic foci, only 1/4 of these patients after 3 treatments still have uptake in the neoplastic foci. So when we see a patient with a large neoplastic focus, then we just combine radioiodine and surgery. So this is an example. Here we have a large lymph node metastasis easily visible on neck ultrasonography. You have another one here, which was behind the jugular vein. And we do a combination of radioiodine, which is given on Monday. Then on Thursday, Wednesday, Thursday, we perform a whole body scan and neck ultrasonography. All lymph nodes are tattooed with Charcot. We inject Charcot and ultrasonographic guidance in lymph nodes, and surgery is performed on the day after, on Friday, with a probe to detect this lymph node with uptake on this one. And then on the Monday after, we do a controlled total body scan. So this is a probe. Here, you see the finger of the surgeon. It's like a pen. It's very easy to work with, and it's extremely effective to find a foci embedded in sclerosis to previous surgery, to find small foci, to find foci in initial location, retrovascular, and to control the completeness of resection. And by doing this, by tattooing lymph node visible on neck ultrasonography, and by using this protocol of combined treatment with radioiodine and surgery, we were able to resect neoplastic foci with uptake in over 90% of all patients. So these results are, I think, extremely good. Now, for patients who have no uptake, the outcome is not so good. And when there is no uptake in lymph nodes, or when there is a capsular fraction, then surgery should be followed by external radiation beam therapy. So this is a rare occasion indication for this treatment.